Good evening, one and all. This is to introduce Dr Sudharasanan MBBS MD. Academic qualification MBBS qualified from Karpada Vinayaka Institute of Medical Sciences and Research Center, affiliated to Tamil Nadu Dr MGR University. Secured All India rank of 476 in NEET PG 2019 and was admitted to MD General Medicine in Government Stanley Medical College. Areas of special interest: internal medicine, core clinical, preventive and interventional cardiology, medical gastroenterology, emergency and ICU management, taking interesting and interactive classes to students. Career objectives: gaining continuous and updated knowledge about the history and epidemiology of various diseases, its etiology, pathophysiology, clinical features, disease management and its complications and prevention. Addressing patients' illness and look for root cause of their problems. To read medicine and cardiology regularly and spread knowledge to others through taking classes, seminars, and interactive discussions, and having interest in learning new concepts from others concurrently. Work experience: internship in Karpada Vinayaka Institute of Medical Science and Research Center, medical officer managing casualty ICU, general wards and labor wards at Ebenezer, junior resident in Government Stanley Medical College and Hospital, Chennai. Then he has done a lot of presentation at regional, national and international conferences. Today he is going to speak on diagnostic approach to tropical fevers.
Good afternoon, everyone. I am Dr. Sudharasanan. Today our topic is about diagnostic approach to tropical fevers. So, I am going to deal the topic with the syndromic approach. Whenever we get a fever case, we have to try to find out the focus of the infection. If you are able to find out the focus of the infection, then it is well and good. We have to send the appropriate tests like blood culture and routine tests. If you are not able to find out the focus of the infection, then you have to classify the syndromic approach like undifferentiated fever, fever with RAS and thrombocytopenia, fever with acute respiratory distress syndrome, fever with encephalopathy, or fever with MOTS. So these are all the most common causes of the undifferentiated fever. We can classify as tropical cause of tropical fever like malaria, strep typhus, leptos, strep, and typhoid, dengue, and other common viral illnesses. So when we go for fever with thrombocytopenia, we have to think of dengue, rickettsia, like strep typhus, and meningococcal infection, malaria, typhoid, measles, rubella, and everything. For fever with ARDS, we have to think of strep typhus. These are all some of the most common causes like strep typhus, falciparum malaria, leptospirosis, and milioidosis, and like severe community acquired pneumonia infections like Legionella, Streptococcus pneumonia, and we have to think of like colic and vascular disorders also like DAH. Then fever with encephalopathy, we have to think of encephalitic cause, mostly viral infections like JE, HSV, varicella zoster virus. Then EBV, CMV, and everything. Regarding meningitis, we have to think of streptococcal pneumonia, Neisseria meningitis, H influenza, and strep typhus can cause aseptic meningitis, cerebral malaria can happen, and there is typhoid also can cause typhoid encephalopathy like smattering, delirium, and everything. So fever with multi-organ dysfunction can be due to sepsis, or falciparum malaria can cause MOTS, or leptospirosis can cause MOTS, scrub can cause MOTS, dengue, severe dengue can cause MOTS. And hepatitis A and E can have acute fulminant liver failure and can go in for MOTS. And macrophage activation syndrome, we are seeing with COVID and everything. It can also cause multi-organ dysfunction. So first I will talk about strep typhus. So scrub typhus is caused by a rickettsial infection. It's a causative organism, the Oriacha susugamici, and vector is larva of chiggers like trombocycloid larva. So it is most common in the sub-Himalayan belt, but nowadays it is more common in our southern part of India also. How the scrub typhus is causing the infection and causing the damage to the human bodies, it affects the endothelial cells. So it affects the endothelial cells, thereby causing the vasculitis, especially the microvascular part. So that in each organ, it will affect the endothelial cells of the each organ, so that it will cause a multi-organ dysfunction state. So the clinical features will be like fever. The most common presentation will be fever, headache, myalgia, and everything. But once the patient go in for severe disease, the patient will go in for MARS like ARDS. Like if it is affecting the lung, it can go in for ARDS. If it is affecting in the brain, it can cause aseptic meningitis, and it can cause myocarditis and DIC and everything. So lab diagnosis will be Will Felix. It is for all rickettsial infection, but it has poor sensitivity and specificity. The gold standard will be IIF, indirect immunofluorescent antibody, and ELISA can be done also with the specificity, and for specificity is around more than 90%. Leptospirosis, most common organism causing this Leptospira interrogans. There are other species also. Source of infection will be direct contact with the contaminated organ, which is mostly present in the contaminated waters. So most common season with the patient will get leptospirosis will be rainy season. So we are having a specific criteria for diagnosing leptospirosis. Is called modified Fain's criteria. So I'll deal with in a few minutes. So the pathophysiology will be both scrub and lepto. The pathophysiology is more or less similar. So scrub also will affect the endothelium, and lepto also will affect the endothelial cell. Thereby it is causing the endothelial dysfunction. This can go in for the multi-organ dysfunction syndrome. The clinical feature again, the patient can have fever, acute undifferentiated phases like fever, myalgia, arthralgia. But once the patient is having severe disease, they will go in for either two phases like anictric phase and icteric phase. Anictric phase patient will have a specific feature, peculiar feature for leptospira is conjunctival suffusion. Conjunctival suffusion, transient rash, calf muscle pain, and the patient will also have the fever, myalgia, and arthralgia. They will also have abdominal pain. And icteric phase patient will go for multi-organ dysfunction like jaundice and pyuria, hematuria, anuria, and they can go in for DAC and ARDS and everything. So this is a modified Fain's criteria. It deals with clinical features, epidemiological factor, and bacteriological findings. Like clinical features, we have to give points for each clinical features. Headache, the point is 2, fever, point is 2, temperature, if it is more than 39 degrees Celsius, it is 2, conjunctival suffusion 4, meningism and myalgia each 4. Suppose if the patient is having all 3 findings, instead of 12, we have to give only 10. Suppose if the patient is having jaundice, then we have to give 1 point. And albuminuria, nitrogen deficiency, we have to give 2 points. And hemoptysis dyspnea, we have to give 2 points. For epidemiological factors, if the rainfall is there, suppose the patient is having fever and they are having these symptoms, suppose if the rainfall was there, we have to give 5 points, because that is the contaminated water is the most common source of infection. So suppose if the patient is having contact with the contaminated environment, we have to give 4 points. Suppose if the patient is having animal contact, we have to give 1 point. So total point is 10 there. And bacteriological findings, PCR, suppose if you are able to identify the leptospira through PCR, so we have to give 25 points. Suppose if we are not able to identify the leptospira through PCR, we can identify the leptospira by serological test like IgM, ELISA IgM, or a slide agglutination test. If it is positive, then we have to give each 15 points. But the thing is, in laboratory findings, we have to do only any one of the laboratory tests instead of all. Suppose if the patient is having PCR positivity and ELISA also positive, means we have to add either one. We should not add two. To the presumptive diagnosis will be to confirm a case of leptospirosis, we have to add scores of each part, like part A and part B. If the score is more than 26, we have to think of the diagnosis made, that is leptospira. Suppose if the part A, part B, part C total, if it is 25 or more, then you have to think of leptospira. If the score is between 20 to 25, then it's a probable leptospira diagnosis. So diagnosis can be, I have already told, it can be direct or indirect. Direct, we have to find the organism through microscopy, culture or PCR. Indirect, we can find it through serological tests like MAT, ELISA and RDT, rapid diagnostic test. MAT, that is the gold standard test. But the thing is, MAT has a very high specificity. But the thing is, it is used for epidemiological purpose. So CPK also can be raised and culture we can do, but the thing is culture is very difficult to do. And MAT has high specificity, that is more than 97%. So these are all some of the images which I have. So you can see with the silver impregnation stain, we are able to find out the leptospira. This is through microscopy, and you can also see the fluorescent staining of this leptospira, and that is MAT. So the agglutination was there in here, here. So that is a control. So we are seeing the agglutination with each side. Here you can be able to find out here, and here also it is there. So then I am going through dengue. Dengue is a flavivirus. Vector is Aedes mosquitoes. Dengue is endemic. It is all over India. So pathogenesis, it is very simple. Dengue is the dengue virus can affect platelet either directly also or through antibody mediated reaction also. But the thing is, if the patient is having infection for the first time, the severity of destruction will be comparatively less. But the patient is having a recurrent infection with the same, there are 4 types of that. So same type or a different type of dengue virus, the destruction will be very much high compared to the first time. So the patient will have a high risk of developing severe dengue. So the dengue will classify with 3 types, like dengue with warning signs, dengue without warning signs, and dengue with warning signs. For each dengue, we have to classify with either of these things. So with warning signs, without warning signs, or severe dengue. So what are the warning signs? There are 7 warning signs are there. So like abdominal pain or abdominal tenderness, and we have to the patient should have persistent vomiting. The patient should have mucosal bleed. And patients should have third space loss, fluid loss, like this because of capillary leakage. So pleural effusion or ascites, and if the patient is having lethargy or restlessness, and the liver enlargement. Usually we will see the GV edema, but we have to see the liver enlargement also. Like if it is more than 2 centimeters, that also comes under a warning sign. And we have to look for CBCs to look for the rise in hematocrit count. This is because of the capillary leakage. So, and we also assess the platelet, how rapidly it is falling. So these are all 7 warning signs. So if the patient is having warning signs, then we have to be very careful, and we have to give fluid accordingly to prevent the severe dengue. Okay, suppose the patient is having severe dengue, it can be due to severe plasma leakage. With severe plasma leakage, patient may go in for a dengue shock syndrome, or patient may go in for EIDS because of this fluid accumulation. And the patient can have severe bleeding. In warning signs, we will have minor bleeding. In severe dengue, we will have severe bleeding. This is due to both decreased platelet, and it is also due to the coagulation factor consumption, which is happening in severe dengue. And the patient can have other morbid features like AST and ALT elevation, urea creatinine elevation, CNS involvement, and other things also. So dengue have 3 phases, like febrile phase, it will be around 2 to 7 days, and they will have a critical phase which is for 1 or 2 days, mostly 1 to 3 days. So this is the phase which you have to have a close monitor of the patient, and we have to treat them accordingly to prevent the patient going for a severe dengue. If you are treating the patient adequately with mostly we are giving supportive treatment only. Suppose if the platelet is falling very rapidly, if it is less than 20,000, or if it is less than 20,000 bleeding, or less than 10,000, we have to give single donor platelet or random donor platelet. Suppose if the patient is having very narrow pulse pressure, like pulse pressure is less than 20 millimeter mercury, then we have to give adequate IV fluid. We can assess the IVC diameter also, and we can assess the urine output also. Based on that, we have to give IV fluids. And followed by, if you are treating the patient correctly, then the patient may go in for a convalescent phase. The manifestations of all the manifestations will be resolved on its own. It will take 2 to 4 days. And diagnosis will be NS1 antigen. It has a high specificity. It's a specificity around 98%, and we can diagnose through serology also, like IgM and IgG. The thing is, IgM we need to wait for 7 days at least. In NS1 we can diagnose it on day 1 also. So next organism is malaria. Malaria, there are many types of malarial species are there, like falciparum, vivax, ovale, malaria, and nolaci. Vector is Anopheles mosquito. The pathophysiology of malaria is there will be a microcirculatory obstruction. This is because of the malaria infected RBC will go and attach with the endothelial cells. Thereby, it will obstruct the microcirculation, so that it will cause multi-organ dysfunction. This mechanism is called cytoadherence. This is more peculiar with Plasmodium falciparum malaria. That's why the Plasmodium falciparum malaria patients will have a high risk of developing severe malaria compared to the vivax and ovale. So clinical features will be like the patients with malaria will have a periodicity. Vivax and ovale will, both are having a tertian fever. They will have a fever spikes for every 48 hours. For malaria, they will have a quartan fever, like fever spikes for every 72 hours. For falciparum, the fever spikes will be intermittent, like some days it will be every day, some days it will be 48 hours. It is not a regular, like it will have a irregular pattern. So these are all some of the manifestations of severe malaria, like cerebral malaria, severe anemia, acidosis, hypoglycemia. They can go in for renal failure. They can go in for ARDS and shock, that is called algid malaria. They can go in for DIC, hemoglobinuria, and everything. This is a pattern of malarial fever. Like Plasmodium vivax, we are having the fever spikes for every 48 hours. Like Plasmodium malaria, the fever spikes is for every 72 hours. This is the Plasmodium falciparum malaria. You can see that there is a irregular every day sometimes. The severity of fever also it is irregular. Like it's around 39 or 40 degree. You can see here it is 38 to 39 degree. So diagnosis will be thick smear or thin smear. Thick smear is to diagnose the parasitic detection. Thin smear for a species identification. The most specific test will be easier to do also quantified QBC, MBQBC. You can identify with the MBQBC. You can identify the malarial species also. The RDT, that is histidine-rich protein or LDH antigens. This is for Plasmodium falciparum malaria. Thing is, it has a high specificity for Plasmodium falciparum. Specificity around 95%. Suppose if the RDT, rapid diagnosis test is, the 2 RDT is negative, we can rule out the malaria. So this is a QBC, quantitative Buffy test. You can see the RBC layer. This is granulocyte, this is lymphocyte, platelet, and plasma. Here you can see the infected RBCs, parasite infected RBCs. So this is a tropocyte form. The sisons will be in the granulocyte layer, and gametocytes is present in the lymphocyte layer. So this is a thin smear. You can see the tropocyte of falciparum, and this is the gametocyte. You can see the QBC, the acridine orange. This is stained with acridine orange, so you can see the orange color. With this, you can identify the species also, and it is easy to diagnose. So my final topic will be typhoid fever. The causative organism is Salmonella typhi or paratyphi. Transmission is fecal-oral route. So it is the pathophysiology is in lepto or strep or malaria. The pathophysiology is they will be affecting mostly the blood vessels. But here this typhoid it will affect mainly the reticuloendothelial cells. So the clinical features will be incubation period will be 1 to 2 weeks. The patient, first week the patient will have a fever, headache, relative bradycardia, that is Paget's sign. The second week the patient can have the abdominal symptoms like abdominal pain, diarrhea, constipation, hepatosplenomegaly. Sometimes the patient going for encephalopathy. The third week the patient going for a Mart's picture or intestinal perforation or bleeding and all. So this is the first week, that is bacteremic phase. Second week, the patient will have widespread reticular endothelial involvement. Because of that, the patient will have splenomegaly and they can have hepatomegaly also. In third week, they will have a GI involvement like ulceration, bleeding, and everything. Finally, the patient is having a chronic stage. Patient will go in for a chronic stage. They can go in for a chronic carrier, like the patient will harbor the bacteria in a gallbladder for a long duration. So they can go in for go and affect the other organs also, like joints, bones, and many disorders. So test will be RDT, rapid diagnostic typhoid test. Typhoid test it measures the antigens, IgM and antibody titers against the outer membrane protein (OMP). So it has a sensitivity of around 95 to 97% and specificity of around 90%. And vital is non-specific. In normal patient also around 15 to 20% it is positive. The patient is normal, having no fever also. So it has lost its important. So we can do blood culture. Blood culture is gold standard. But the thing is, bone marrow culture is very much having a high specificity and sensitivity compared to blood culture. With bone marrow culture, even after 5 days of antibiotic, the bone marrow culture will be still positive if the patient is having typhoid fever. So this is approach. I think this is not good. This is approach. The thing is, whenever you get a patient with fever, you try to find out the focus of the fever. If the patient is if you're able to find out the focus of the fever, like the patient is having pyelonephritis, community organia, acute pneumonia, or osteomyelitis. If you find out the focus of the fever, then you do appropriate investigation and treat them accordingly. If you are not able to find out the focus of the fever, then you try to make a syndromic approach. You made it as a fever with ARDS, a fever with RAS, fever with encephalopathy, fever undifferentiated fever. Then you order investigation accordingly. So you ask for common tropical infections like scrub, lepto, typhoid, malaria, and dengue. If everything comes out negative, then you have to after extensive approach, if it is everything comes out negative, then you have to evaluate like PU. So my topic is about common approach about the common tropical fevers. So regarding treatment, next class. So Dr. Harrison.
Dengue mosquito is a day biter, that's confirmed. Yes. It's a day biter.
Yes, early morning.
Early morning biter. They say dengue.
They don't do it in the night.
There is a saying that evening also is okay.
They still true or it's
No, they don't bite in the night.
Different schools of thoughts. Evening or study, early morning or study.
Night like that.
இல்ல இருக்கு சார்
The why especially said then
dengue is a day biter.
they bite
We used to say not of those days. Dengue mosquito means
day biter.
and that only the female mosquito will bite. Male mosquitoes don't bite as usual.
as usual.
They survey plant uses, sir. Yeah, most of the male mosquitoes are vegetarian.
Very precise
Survey
talk,
only
any
of plant uses.
Request Dr. Kailash, he's our Vice President, Labor Chairman of the Board. This is a meeting of this person.